Hi guys, my name is Noor. I'm a ST1 ophthalmology trainee. I've made this teamed up with the Finals Ophthalmology Society, Mariam from their side, who is lovely and you'll meet in a bit. I've teamed up with them to bring you this high yield, quote unquote, lectures for Duke Elder. We might be doing it as a series, so there might be more lectures to come. But for now, we've just got this one, which should hopefully cover most of the information just that you need to know just before the exam. So it was delivered as a live webinar just before this exam in August 2024. They say in medicine that 20% of the knowledge can get you 80% of the marks. So that's the kind of situation we're hoping for here. It's definitely not by any means a lecture that covers all of the content, but we are trying to deliver it so that people who have been preparing they can kind of just run through this once before the exam and kind of have some sort of a good standing. When we gave this lecture, so I was about 3-4 weeks into my ST1 training in ophthalmology, after having come from foundation training, and Mariam is a final year medical student, so that's kind of our level of knowledge in terms of our ophthalmology knowledge. We're not consultants or anything or experts in ophthalmology, so you know, take what we say with a pinch of salt. Do your own research, read your own textbooks, etc. We're just trying to deliver what we think is right, but we could always be wrong, and everything we're saying is just our opinions, really. So yeah, don't quote anything. We have tried to make illustrations of certain key concepts. We couldn't use, for obvious reasons, pictures of patients or pathology on YouTube, so please excuse the drawings. They're not highly skilled, but hopefully the diagrams do bring across what we're trying to say in terms of getting the marks for the exam. Last thing is, we're gonna put a feedback form link in the description. Please fill that out. It's always really helpful for us. Let us know what you liked or didn't, and if you do that, you can get a copy of the slides as well, which would be good for your revision. So I hope you enjoy this. Leave a comment if you know, honestly, good, bad, I'd be happy to hear it all, but I hope you find it useful, and see you on the inside.
Yeah, perfect. So hi guys, I'm Mariam. So I'm finally a medical student at HIMSS, also part of the HIMSS Ophthalmology Society, and I've done an integrated master's in clinical anatomy, and I'll be covering some bit of the anatomy, which we think is quite useful for Duke of Elder. And again, thank you so much for Dr. Noor to take out time off. I think she's just coming straight from the clinic as well, so it's quite busy being a trainee. But yeah, we were grateful. Thank you.
Oh, thanks. Hey guys, this is the high yield Dear Gelder from HIMSS, and then the ophthalmologist is me, basically. Okay, so this is what we're going to try to cover from each of the different sections. This QR code is where you're supposed to be able to like access the talk afterwards, because we're recording it, and then it's going to be put on the YouTube channel, and you can access the YouTube channel from this. Right, so if you scan that, yeah, you can get the recording on there. Mariam's going to start off with the anatomy of the orbit.
Yes, so I'm sure at this stage, you know, have a basic understanding of the bony structure of the orbits, and it's quite complicated. And I like to think of it as a tilted pyramid. So that's why I put a nice picture of pyramid right at the top. Can you hear me? Okay.
Yeah, I can hear you.
Yeah, okay. So as I was saying, so orbit looks like a pyramid, which is like, if you imagine, it's like tilted on the side, and in a sense that it has apex, so right at the top, where the different walls of the medial, if you look on this side where the nasal bone and lacrimal bones, so medial, lateral, floor and the roof come together to form an apex, and apex is where the optic nerve is able to access the brain. So the images that you see from your eyes are kind of pictured on your retina, and then go to where your optic nerve to your brain for the rest of the visual pathway. In terms of what structure, so it is quite. I know I do recognize this is kind of brute memorization at this stage, But I think the main takeaway from this is like the roof is formed by frontal bone, and then we have got less wing of a sphenoid, and which kind of forms the major part of the roof. And then in terms of floor, we have got maxillar bone, palatine, and zygomatic bone. And with the medial wall, which is the thinnest wall of all, is formed by the ethmoid. So you have sinuses in your face. So there are four main sinuses. So you've got maxillary sinus, which is kind of makes the most of your face, and then you've got ethmoid sinus. So the wall of the ethmoid bone, which is of the sinuses, forms the medial wall, and then above the sphenoid bone kind of strengthen it. And then we finally have the lateral wall, which is formed by your zygomatic bone and the greater wing of the sphenoid bone. So these form the main structures. So I think just try to remember, frontal bone is the roof, and then zygomatic most of your lateral wall, and then medial is the thinnest wall made by ethmoid maxilla, and floor is again your maxilla and your zygomatic. So if we go on to the next slide. The reason I mentioned this bony anatomy is to talk about a little bit about the clinical manifestation. So even though I said the whole idea of orbit is to protect the eye. So if there's any force onto the eye, it needs the walls of the orbits acts as a cushion. And I did say the medial wall is the thinnest, but when there's a fracture when there's a trauma to the eye, medial wall is not the first one, is not most likely to be fractured. And the reason for that is that medial wall is actually strengthened by the ethmoid sinus. So ethmoid sinus acts as a second layer of support, whereas the floor of orbit is more vulnerable because it's made of like three small bones, as I kind of touched on it. So like a bit of your palatine bone makes up your floor of orbit. So if there's a trauma to the eye and the force has nowhere to go, it's more likely to go to the weakest area, and that is the floor of the orbit. And if there is, and this is what we call orbital blowout fracture. So any trauma like a tennis ball hitting the eye, if the force goes through the floor of the orbit, and it tends to impede the inferior rectal muscle. And I'm sure you would know the muscles at this stage. So you've got superior, which helps move the eye upward, inferior, which helps move the eye downward, and then you've got medial, lateral, you've got superior oblique muscle there as well. But the key takeaway is that from this slide, in an orbital blowout fracture, if this patient is being asked to look up, but you can see that patient is not able to look. So one of the eye is projecting downward, and that's because the inferior rectus they don't have control over the inferior rectal muscle, which is supposed to bring the eye down. And that's what happens when there is a blowout fracture to the orbit. Another thing I wanted to mention here is the medial wall. So the medial wall is the thinnest one, and that is also the commonest site of the infection. So usually if there is because the wall is so thin, if there's an infection in the ethmoid sinuses, it can get into the orbit and become something called orbital cellulitis and spread into the orbits. And that's something I'm sure Noor would mention later as well. It's something we worry about, and it's considered like an eye emergency. Okay, so that was just like a whistle stop tour of the orbital eye anatomy and the main pathology that's associated with it.
Thanks. Okay, so we had planned to make this interactive because I think it's close to the exam, and the best way you learn is just by kind of questions and like spaced repetition. So if someone just wants to shout out, I think if someone just shouts out, please, which answer they think is correct.
C.
Chat.
We've got someone in the chat saying C.
Okay, yeah, we've got people in the chat saying C. Yep. Okay, that's great. Yep, well done, guys.
So the cornea is made up of 5 main layers that you need to know. And from front to back, they can be remembered using the acronym ABCDE. So A being epithelium, so you have to kind of imagine the E, it sounds like an A, epithelium. B, Bowman's membrane. C, stroma, again the C and S sound similar. D, Decimase membrane. And E, endothelium, which is of course going to be the inner lining of any structure, as we know. So starting with the epithelium, which are the layer of cells you can see in red in the diagram. The main point of this is, of course, it forms the outer surface, so it obstructs the passage of any kind of foreign objects into the eye. But a big thing it does is that it absorbs oxygen and nutrients from the tears, so from the tear film, and then it distributes these nutrients to the rest of the cornea, which I always think is really amazing. It also has a lot of nerves. So for example, obviously if someone touches your eye or you get something into your eye, you feel it a lot, and that's because you have all these nerves on the cornea. And after that, you have the Bowman's membrane. That's essentially an acellular layer. It's just made up of type 1 collagen fibers. Then you have the stroma of the cornea. Now, this is important because it contains very regularly aligned fibers, and the reason that it's important that they're regularly aligned is because that allows us to have a really clear window into the back of the eye, because the fact that they are so regular allows light to travel straight through them. If there is disruption of the alignment, etc., you start running into problems, and then the window of the eye becomes cloudy. This stromal layer accounts for almost 90% of the cornea's thickness. So as you can see, the layer in purple is covering most of the section of that diagram. And it's primarily made up of water and collagen. And it is the most important layer in kind of generating the cornea's light conducting transparency, which I was talking about. As we know, the cornea is responsible for a big part of the eye's focusing power. And so the two things that contribute to that are the cornea and the lens. And so this layer then obviously has a big part to play in that focusing power of the cornea. We then have Decimase membrane, which is actually secreted from the endothelium layer underneath, and it's quite interesting. It actually thickens as you get older. So you start off with around 5 micrometers, and then as you get older, you end up with around kind of 17 micrometers of thickness of the Decimase layer or membrane. Then you have the endothelium layer, which is the layer in grey on the diagram, and this is again crucial because it has a lot of ion channels that move ions to essentially maintain a dehydrated stroma. They move them in such a way so that water follows, and then the stroma maintains that kind of dehydrated state, which again maintains this transparency, which is important for what we were speaking about earlier, the transparency and the focusing power. If the so in a normal kind of functioning eye, fluid normally is draining slowly from the inside of the eye into the stroma, so the middle, so it's kind of draining from the inside to the outside, and the endothelium is constantly acting to pump that excess fluid out. And then if the endothelial layer becomes ineffective at doing this, then the stroma will begin to swell with water, and then that will lead to your vision becoming hazy and opaque and blurry, etc. So the endothelial cell layer actually plays a crucial role in maintaining a clear cornea. Because the endothelium is so important, it's actually something that we try to preserve quite a lot when we're doing cataract surgery. So we will use viscoelastic
or particularly if a patient has a corneal dystrophy, we will use something thicker to try to preserve the endothelial layer, because it is also something that doesn't regenerate. So the epithelium is constantly regenerating, and that's fine. You know, for example, if you have a corneal abrasion, it will eventually heal if it's not too large, for example. The endothelium, however, you've just got a certain amount of cells, so you've got about enough to last you 200 years. And that's it. It never regenerates. So you have essentially kind of double the amount that you need, because normally most people live around 100, right? So it can sustain some damage, but not very much. So we really try to preserve the endothelium when we're performing any sort of surgery, and that's the reason that we will insert some things like viscoelastic, and that's to prevent the heat from the instruments that you're using. So for example, for cataract surgery, the phaco probe produces a lot of heat. If we didn't insert something like a viscoelastic to prevent that heat reaching the corneal endothelium, then it would basically destroy the endothelium. And even if we have removed a cataract, the patient will not be able to see because of the mechanism that I just described, which is if you've lost the endothelium, the stroma is going to swell up, and then the patient will be blind, because the stroma will just obstruct their whole vision, even if they have no cataract. It's also a good idea to learn these layers because you have different types of corneal transplants. So I won't go too much into that right now. I'll leave you to look that up in your own time. But you can have different corneal transplants that target different parts. So you can actually replace layer by layer some of these cells, which is fascinating. But look into those, and understanding these different layers will help you to understand that.
Okay. So how about this next question? This one might be a bit more tricky. Try to start off easy. Mariam, can you let me know if someone's commented in the chat, because I can't see the chat on my screen?
Yeah, sure. I'll read out the chat.
Okay, thanks. Okay. Just have a go, guys. It's good if you get it wrong and then it will like stick in your head. So it's essentially a contact lens wearer with a very painful but not very red eye. And then they've got keratitis. And then you can see the pathogen that's caused the keratitis in this picture here. Oh, have we got someone in the chat?
Yeah, so we've got two responses. Someone saying D. So we've got three people saying D.
Okay, fine. So the answer was actually B, but hopefully you'll remember it now. So I'll try to go through it. It's a bit more tricky, obviously, than the first question because it's kind of got two layers to it. Does anyone want to say why they thought it was D? Everyone too shy? Okay, don't worry. So some of the questions in Decile, they do tend to be kind of double layered. They require a bit of thinking. So I have tried to do that with the questions in this lecture, which does make it a bit more tough. But essentially what I was hinting towards is acanthamoeba. So the first part, which is contact lens wearer, so acanthamoeba, we'll go through it properly in a second, but it's very typically associated with contact lens wearers. The fact that we've mentioned here, painful but not very red, that is kind of pointing towards something known as here, like pain I wish I could point with my mouse, honestly, but it's pain disproportionate to clinical findings, which is what you can see is one of the signs. So the typical way we say that is the patient's complaining of so much pain, but then you see and it's like, okay, it's not very red, it looks not that bad. And that's really a classic kind of exam description of acanthamoeba again. And then the last thing is the calcoflower white stain. So the calcoflower white is something that picks up, it can pick up like fungi, it picks up acanthamoeba, stuff like that. And acanthamoeba has quite a typical appearance with the calcoflower white. It has this kind of double-walled cyst appearance, like you can see in the picture. So if all those clues, like the clinical presentation as well as the staining, should hopefully have led you to think it was acanthamoeba, and then it's asking you for the corneal finding of acanthamoeba. So I apologize if it was too hard, guys, but yeah. So the corneal finding of acanthamoeba, very pathognomonic, is perineural infiltrates. Does anyone know what perineural infiltrates means? No. Okay, so basically, I couldn't figure out what it was for a long time, and I just learned it off by heart. But then again, this is why I need the pointer now. I hope if you can see the picture on this screen on the right, and then if you start kind of from the most right corner, moving inwards towards the left. So on the left is the pupil, and then you can see the cornea going towards the right. And then you can, where you see that black bit going into the blue, if you can appreciate, there are some kind of straight white linear things going in from the black bit into the blue bit. Essentially, those things are nerves that are going into the cornea. So the cornea is pretty cool because it's like one of the surface structures where you can actually see nerves. So yeah, so the black stuff is from the black bit, the white stuff going into the towards the pupil, those are the corneal nerves. And the reason you can see them here is because they've become really edematous. So that is what is called a perineural infiltrate, and you can see it when you on the slit lamp when you examine. So acanthamoeba, it's kind of the typical one that everyone gets terrified of. Like all the ophthalmologists, they're like, oh no, like you can't miss acanthamoeba. So, but it is actually really rare. But the reason that everyone gets scared about it is because it's associated with a really poor prognosis. So people go blind. It's often really typically misdiagnosed. And the reason for that is because people think that they will see like we'll see dendrites. So that's why, like, you had option A, for example, dendrites. That's quite typically associated with herpes, keratitis. But with acanthamoeba, you see something similar to dendrites, but they're basically pseudodendrites. And that's why it's typically often misdiagnosed as herpes, and then the patient's sent home, and then they come back and they're basically gone blind. So that's why everyone worries about it. It's a really poor prognosis. But that's why they love to examine you on it as well, because the patient will be complaining of a lot of pain, but you look and there's nothing really there, maybe some query dendrites, and then you send them home, but you've actually just massively messed up. Okay, so in terms of the other signs you get with it, so the pain disproportionate to clinical finding, perineural infiltrates, you get a ring abscess as well. There's a picture of that coming up in a few slides. It essentially looks like a very clear like ring. And then the calcoflower white stain is the stain you can use to identify it, on which it looks like the double-walled cysts. Typically, the actual organism it's a protozoa, and it's found in soil or like fresh or like brackish kind of, meaning like kind of salty water. And because of that, you'll typically find it in people who have been washing their contact lenses in tap water instead of the actual solution that they're supposed to wash it in. And it has a really weird treatment regime as well. Like, we don't normally use this for kind of bacterial or viral keratitis. So chlorhexidine, or this really long word, polyhexamethylene biguanide, PHMB. And you give that for several months. I'd say just learn the word, like the letters PHMB. This exam is just all about like pattern recognition. You don't even need to understand that much. So I've kept it minimal on the slides so that you can just go back and have a quick look and be like, okay, pattern recognition. I hope that all makes sense. Miriam, if there's any questions in the chat, will you let me know?
Yes, I'll read out any questions. So
Thank you.
far,
Because
no questions.
I think I got a notification at some point that there was something in the chat, but I don't know how to click on it. So
There might be the answer to the last one, but I can see the chat and I'll just read it out loud. Any questions?
thank you.
No.
Okay, nice. Okay. So I hope that makes sense. C, the limb inflicting thing. So that's just something random that's caused by essentially a corneal condition called like tenulosis, and that's by the staphylococcus antigen. Some people, if you have like hypersensitivity to it, you can get that. So you just need to know the dendrites for HSV, the perineural infiltrates for acanthamoeba, and yeah, that's it. And we'll go to the rest in a bit. Okay, so what pathogen do people think could have caused this picture on the right? Streptococcus, pyogenes, herpes zoster ophthalmicus, herpes simplex, or varicella zoster?
So we've got a couple of answers. Bees. There's another B, another B, bees. I think everyone agrees that it's B.
Okay. Okay, so I did this on purpose, and again, it's kind of mean, but they could totally do this. So it's actually D. And that's because herpes zoster ophthalmicus is not a pathogen. So it's varicella is the actual pathogen. The condition is called herpes zoster ophthalmicus. It's caused by the varicella zoster virus. So that's just a bit of a like a technicality, but they can easily catch you out on it. Strep pyogenes, that's just group A strep, so it can sometimes cause like bad skin infections that can look kind of blackish sometimes, but it's obviously not this because this is very dermatomal. As you can see, herpes simplex, as we know, is like the cold sore one. And it typically, again, doesn't cause this dermatomal distribution. So what gives it away here really is that very typical dermatomal distribution of shingles, which is caused by the varicella zoster virus, and then the condition is called herpes zoster.
No, there's a question in the chat. Someone is asking if they do have this, are they sent to emergency eye department or they can be treated safely by GP?
So it depends. So it depends how bad the rash is. And that is where the Hutchinson sign also comes in. Anyone know what that is?
So when he says saying lesion on tip of nose, nasociliary involvement, and Lillian is also saying tip of nose.
Exactly. That's great. Yeah, I'm glad you got the nerve as well. So yeah, it's the nasociliary branch of the ophthalmic division of the trigeminal nerve. And that is essentially that, as well as any eye signs, are going to differentiate whether it can be treated by a GP or an ophthalmologist. For the sake of the Duke Elder, you don't really need to go into that. I wouldn't even bother. The Duke Elder is literally just about knowing keywords. So such as Hutchinson sign, know that it's caused by the varicella zoster virus, and just know that it causes dermatomes. But for future, like when you're practicing, yeah, you want to see. So I think I was literally on call yesterday, and I got this exact question actually by a GP who had a patient come in to him. And they had the dermatomal distribution, and they didn't have the Hutchinson sign, but the patient was starting to get like redness of the eye, and they're complaining of blurry vision. So we asked them to come in. So any visual symptoms, so like redness of the eye, visual acuity going down, or if they have Hutchinson's, then they will need to come in and get assessed. Otherwise, if it's just like a little bit of a rash, on the forehead, or whatever, it's generally fine. Although we would advise like strict monitoring by the GP. We would say at the start, just if the GPs, it depends again how confident the GP is as well. Like if they're confident in measuring the visual acuity of the patient, which in my experience they often don't have the chart and things for it. and they can document that it's fine, then it's okay. We probably don't need to see them. But otherwise, if they can't do all of that, which in my experience, they normally can't, then we'd get them at least seen initially in the emergency eye department. We'd get them started on acyclovir, and then we would ask the GP to monitor like daily, for example. But as long as it's just a rash. But if it's spreading to the eye or Hutchinson signs or anything like that, then we would monitor more closely. Does that make sense? But for the sake of the Duke Elder, you don't need to know any of that. You just need to know the virus, the typical distribution, and the fact that it's essentially shingles, and the treatment, which is ganciclovir or acyclovir. And just do keep in mind post-herpetic neuralgia. So even after the rash is gone, patients can have that essentially for years, sometimes forever, and they might need kind of things like pregabalin to help with the pain. It can cause quite severe pain for the rest of their lives. Does that make sense? Yeah. Okay. So this is a quick so I think it's kind of self-explanatory for bacterial keratitis. We want to give one of the fluoxetins. We wouldn't really give some stuff like chloramphenicol, for example. That's not really good enough. You need the stronger stuff. For viral, you want to just the two main types you need to know are herpes simplex. So that's the one that's caused by the typical cold sores. You just ask the patient if they've had a history of cold sores. And then also, if you do fluorescein staining, you can see on front of the cornea dendrites, and they're really clear. Like I actually saw one yesterday on my own call, for example. They do tend to love asking in exams for some reason the side effects of acyclovir when you give it. The typical one, it's just diarrhea, as it is for most drugs. And the other thing is just to make sure you check kidney function, because you can't give it with like very low kidney function. And then the other one is the herpes zoster, which we've just gone through, which is the varicella zoster virus, reactivation of that, the dermatome, Hutchinson sign, mesociliary nerve, etc. You can have fungal keratitis as well. So with that, there will often be a history of the patient gardening, for example, and something's gone in their eye, and then you have a look. With fungal, it often looks kind of like a whitish, or like if you've ever seen kind of candida, like those kind of like yeasty, whitey blobs on the cornea, which is very different to, for example, the typical appearance of a dendrite in the viral or even with the bacterial. And then you have protozoa, and the main one to be aware of with that is the acanthamoeba, which we've gone through. We know now what the perineural infiltrates are. Pseudodendrites, so they look different to the herpes simplex dendrites. Sorry, I don't have a picture of them, but you can look them up. They're essentially just a bit different in morphology. And this is a picture of what the ring abscesses with acanthamoeba look like. So they're really obvious. It's very typically like a ring if you compare it to the bacterial picture, which is the full kind of circle is covered with the bacteria, whereas acanthamoeba, it's clear in the center. Okay. So moving on to the kind of front to back of the eye. So we've done like the orbit, cornea, going kind of more backwards, posteriorly, going into a bit of glaucoma now. What do people think for this one?
So we have got a lot of D's in the chat. So pretty much everyone is saying D for this question.
Nice. Okay, I'm glad everyone got it. I've realized a lot of my answer choices tend to be D's. I need to change that. Okay. Yes, well done, guys. So you got essentially the trick, which is an increase in intraocular pressure. So all of the other three things are glaucoma drugs that we use. They will all decrease intraocular pressure, and you'll see in a second the mechanism of action of all of them. Anticholinergics, they will increase the pressure. So for example, you have atropine, which is a parasympathomimetic, and it will end up dilating the pupil, and then that will cause pupillary block. And then when that happens, the iris kind of will bow forward, blocking the drainage through the trabecular meshwork, and then you can get angle closure. Oh. Okay. So you have alpha agonists. These are all, this is just, again, you can take a screenshot of this if you want. This is just a case of learning the different glaucoma drugs. One easy way to learn the first two is just like alpha agonists. So like A and then similar and then beta against. I that kind of have always made sense in my head, like the double A's and the double B's. So alpha agonists and beta blockers. Alpha agonists do both increase the outflow and then decrease the production. And the main side effect to learn is just dry mouth. Obviously, they have loads, and if you read like textbooks and things, they'll have loads, but these are just the main ones to learn it for like MCQ purposes. And you have things like timolol, which we give really frequently. That just works by decreasing the production. And the main thing is not to give it in asthmatics because it can cause respiratory depression. Carbonic anhydrase inhibitors like acetazolamide, which I think you also use for mountain sickness. That decreases the production, and sometimes they'll ask the typical side effect, which is just a weird metallic taste or tingling in the peripheries. Pilocarpine is one of the cholinergics. So if it's a cholinergic, it will decrease the pressure. And if it's an anticholinergic, it will increase the pressure. And that will cause blurry vision because it's essentially going to cause a small pupil, which will cause blurry vision. And then you have any of the prostaglandin analogs. The main thing is the hypertrichiasis, so long eyelashes or like weirdly shaped, growing in weird direction eyelashes. As well as hyperpigmentation. So it can actually cause kind of pigmentation of the iris, or it can cause pigmentation around the lid as well. And it can cause, I think, a little bit of the fat around the lids to dissolve as well. But it can cause nice long eyelashes. And so a lot of people in the cosmetic industry like to use it for the long eyelashes thing, but they don't realize that it can actually cause all of the fat around the orbit to dissolve, which actually just makes you look more old. So yeah, don't use. Okay, Mariam, did you want to do the retina bit?
Yes. Right, so we're going to do again a quick question. So which layer of retina has photoreceptors cells? Right, so getting a lot of B's. I can spot 2 D's and 3 B's. Right, I think it's a tie. Correct answer is D. So it's the retinal pigmented epithelium, which has the photoreceptors, so your rods and cone cells. So if we go to the next slide, I've got a picture which shows the different layers. Now, with the retina, I'm sure you know the retina is the innermost layer of the eye, and that kind of covers the 2/3 of the globe of the eye, and it's a neurosensory layer. So it's essentially it's a layer which has a lot of axon cells, and as you can see in the right, and these are just some of the layers that have been named so far. And I think so far we know 11 layers, but it could be many more. Or right now I'm speaking, there might be someone discovering the 12th layer. But the whole point of putting this picture up there is that the main takeaway from this is that there are 2 main components of the retina. So there is a retinal pigmental layer, which is right at the bottom. You can see the pigmented epithelium is right at the end, at bottom, and it sits above the choroid layer. And choroid is the layer of the eye, which has which is highly vascular, and that's I think part of the reason why pigmented epithelium is so at the bottom. Yeah, so essentially the two major components of retina are, so we go retinal pigmented epithelium. So when the light come in through your outer layer, then going through your cornea, then ends up on your retina. It goes through all of these layers, and then in your photoreceptor cells is where it's then converted into the phototransduction happen, and signal pathway continues there. The rest of the retina is neurosensory, and from an evolutionary point of view, it's kind of counterintuitive to have like so many layers. But yeah, in terms of what can go wrong with retina, so you can have retinal tears, and things like that usually presents as like floaters or flashes, and I think I think that's kind of the main. Or you can have retinal detachment, so when the retina detaches, and then again the floaters and flashes what you see in these patients. But yeah, I think that I just wanted to mention that you don't need to know all of these layers.
Okay, nice. I would also just mention, guys, with retinal detachment, I think because we just haven't done a slide on it, but I would assume pretty much everyone knows it by now, but just remember like the 4 Fs, so floaters, flashes, field loss, and falling, so like a decrease in acuity. And you normally get that kind of curtain over your vision. And the typical sign that they like to ask for is called Schaffer's sign. Anyone know what that is? So it's essentially when you see pigment in the vitreous. So you on the slit lamp exam, if you ask the patient to look up, down, left, and right, and then look straight ahead, you will see kind of glistening bits of pigment. It looks quite pretty actually in the vitreous itself. And that if you see that, then that means there definitely has been either a tear or a detachment somewhere, and you have to do a full examination. And like even if you can't see it on imaging, because imaging doesn't cover all of the peripheral retina, you have to make sure you examine it properly, because there definitely is a tear. So it's called Schaffer's sign. Just a quick one on ARMD. So this is essentially a condition that kind of is associated with age. Two main versions that you need to know about is dry and wet. So for dry, the main risk factors are like getting older, smoking, being female, Caucasian, and being hypermetropic. The main thing you need to know for ARMD in terms of the exam is just that dry equals drusen. So if they describe drusen and they describe the typical visual findings, anyone know what the visual findings are for ARMD? So it's those typical kind of wavy lines in the center of your vision. You see it on something called an Amsler grid. So the patient will say, I can see everything. It's not like, there's any black spots or anything in my vision, but it's just that when I try to look at straight lines, so for example, if they look at like a bathroom floor or something, a tiled floor, instead of the lines being straight, they'll just appear wavy in just the middle, and that's because of the drusen near the macula, or the fluid near the macula. So yeah, if a patient has any of those typical findings in the text of the question, and then it just mentions drusen, but it doesn't mention anything else, then it's just dry ARMD. And if they and the management for that is essentially just supportive. You can tell them to stop smoking. Some people say that some vitamins help as well. But if they say that, they've had a look at the back, they've got those symptoms, and there is also fluid at the back, then we call it wet AMD. And in that case, the patient might also have like a blind spot in the middle of their vision, like the vision might actually be like completely gone or black in the middle rather than the waviness. And the good thing about wet AMD is we do have treatment. So rather than kind of the supportive / smoking cessation, which is all we have for dry, for the wet side of things, we do have anti-VEGF injections. So that's anti-vascular endothelial growth factor injections, which are intravitreal, meaning we inject them through the globe and they go straight to the site. And the mechanism behind that essentially is that the reason that you get kind of fluid at the back of the eye, and it's the same for diabetic like macular edema or any kind of macular edema. The pathophysiology is always the same. You are getting fluid at the back of the eye, and the reason for that is because you've got fragile vessels, blood vessels at the back of your eye that are forming because there is ischemia to the back of the eye. Whenever you have ischemia, your body tries to compensate for that by producing fragile new blood vessels at the back. But because those blood vessels are fragile, they are breaking down, leading to an accumulation of fluid behind the eye. And so that's why the anti-VEGF works. It essentially stops the endothelial growth factors, which are the growth factors that are being released from the ischemia. So if the growth factors are no longer being released, then you are no longer going to get neovascularization, and then you're no longer going to have a risk of a bleed. So I hope that makes sense. This has actually been something that's revolutionized the treatment of ARMD in ophthalmology over the last few years. Before that, we didn't have anything, and now patients are coming back with this and reporting an actual, sometimes even an improvement in vision. So it's pretty good. This is just a quick one. As in because it's literally just a case. I would say just go home and learn basically the slide, the diabetic grading. So R0 is no retinopathy. R1 is just background, some microaneurysms, small hemorrhages, hard exudates. R2 is pre-proliferative. So IRMAs, venous beading, and then cotton wool spots are characteristic of that. And then you have R3, which is proliferative. So NVD, which is new vessels of the disc. 1DD is one disc diameter. So the definition of new vessels of the disc is if you have new vessels, so that neovascularization I was talking about, if you have that within one disc diameter, within one optic disc diameter, then that of the disc, then that's referred to as NVD or NVE, which is new vessels elsewhere. And then you'll also have M0 or M1. Yeah, based on which of the first three you have. Diabetes, diabetic retinopathy is associated with parasite damage. Parasites are essentially the cells that go around the capillaries in the back of the eye, and they get damaged, and that is what leads to leaky capillaries. And those leaky capillaries lead to small hemorrhages, or even like larger hemorrhages, cotton wool spots, etc. Or cotton wool spots are actually ischemia, but yeah. Okay, so next question. 19-year-old man with night blindness has this retinal appearance. Which mode of inheritance carries the worst prognosis?
So we have got Vanessa saying D, Minna D, Ali D. Yeah, so most people are saying D in the chat.
Nice. Okay, great. I think I messed up and I've like accidentally just put D as all of my answers for this PowerPoint. And I don't know how that's happened. But yes, it is D. Well done, guys. So the condition is retinitis pigmentosa. It's the most common hereditary fundus dystrophy. It can be inherited in autosomal dominant fashion, autosomal recessive, or X-linked recessive. But X-linked recessive is by far the most severe in terms of the prognosis. I think it is the least common, but it's the most severe. In terms of the options, X-linked dominant, I've not really heard of that being one of the inheritance patterns for this condition. But you do have the other three, A, B, and D are, and then D is associated with the worst prognosis. So the way it works is you essentially have it's a gradual kind of affecting of in terms of the the type of photoreceptors it affects is gradually starts from the rods, and then eventually it can affect the cones, and then eventually it can affect the retinal pigment epithelium as well. The reason that it's significant about the order is because it affects the rods. So patients often report night blindness, which is basically they say that like I can't really see as well as nights, as well in night. And we know that that's because rods are responsible for most of our night vision, and for the low intensity light vision. So they'll often also, patients will often also say, you know, I can look at something like head on and I can see it, but I can't really see kind of the peripheries, and that's the kind of tunnel vision they describe. So yeah, just if you do see tunnel vision, don't always just think glaucoma, you know, sometimes it can be this as well. And with this, typically in the stem of the question, there will often be some sort of like a inheritance clue mentioned, like their dad usually has it, and then it's the son that has it. And then on the exam, when you look at the back of the eye, the fundal exam, you'll see the bony spicules. So as you can see on the top image, you can see those kind of black bits on the mid-peripheral part of the retina. They kind of start from there and then gradually move inwards as the disease worsens. And the reason they're called bony spicules is if you've ever seen kind of like the inside of a bone, the pattern of that kind of looks similar to this. So I think that's why they called it this. And then you can also see a waxy pallor of the optic disc, again on the top image if you see, and then you can see arteriolar attenuation. So that's what you see in people who actually have the condition. And then you can also have carriers of the condition because you have, for example, multiple different inheritance modes. And in the carriers, they can usually have either a normal fundal appearance, or they can have a fundal appearance that's typical to the one that I've shown on the bottom picture, which is what we call like a golden metallic tapetal reflex at the fundus. So what that means is if you're shining a light at the fundus here in the bottom picture, you're seeing that kind of golden yellow glow, again, more visible on the bottom part as opposed to the top part of the picture. So the top part is what a normal fundus more typically looks like, which is red and orangey. But on the bottom bit, you can see a bit of more kind of a yellowy glow. And that's what you typically see in carriers of this condition. And this condition can cause things like a posterior subcapsular cataract as well, which is quite common. So although there's no treatment for this condition itself because it's genetic, a cataract surgery can often help patients for that reason, for the posterior subcapsular side of things. And some people also suggest high-dose vitamin A, but that's controversial at the moment for this condition. And then the other thing it can cause is a posterior vitreous detachment, which is essentially when the vitreous starts to pull away from the retina. And that can typically happen as you get older. It's quite common, but in this condition, of course, younger patients can get it as well because it's a hereditary condition. And the typical, not the typical, but the one of the most sensitive diagnostic tests for this is something called an ERG, which you can do as well. Okay, next question. 25-year-old Scandinavian female presents with pain on eye movements and red desaturation. Given the most likely diagnosis, what is most true regarding giving steroids? Given the most likely diagnosis in terms of Duke Elder, by the way. So And then we're assuming we're giving steroids. What's most true? So they improve the long-term prognosis, they improve the recovery speed of the current episode, they improve the visual outcome of the current episode. Gastric prophylaxis should not be used alongside the steroids.
So in the chat, we've got B. We've got 4 people. Everyone is saying B. And another B. Yeah, B. So improve recovery speed of current episode.
Nice. Good job, guys. Okay. I think people might be good in terms of their prep for this side of things for the exam. Well done. So yeah, so the condition is obviously optic neuritis because you've got the typical pain on eye movements and red desaturation. Those are typical features of optic nerve damage. Red desaturation is actually quite a good differentiator for optic nerve damage in particular. So optic neuritis is a condition that typically affects females with a 3:1 female to male ratio, mostly younger females, aged 20 to 50, and you have a higher prevalence in Northern Europe. So that's why in this time, for example, the girl was from Scandinavia. It also has typically, for some reason, has an incidence in people who have moved to Europe or Northern Europe that were originally from kind of countries below the equator. So if you have, like, for example, an Asian person or an Afro-Caribbean person that's moved to a northern part, and I think there are currently studies investigating whether with lack of vitamin D might be associated. And those are all things, those are all the demographic things because they are all also the demographics for multiple sclerosis, which is what this condition is typically associated with. So on this image here, you can see T1 weighted MRI showing the periventricular plaques. So you can see the ventricles are white because it's T1 weighted. So the CSF is white, and then you can see around the ventricles in the middle, you can see a hyperattenuation of the brain, which you wouldn't typically see in a normal one. Maybe I should have put a normal image to compare, but I hope you guys can appreciate that. And optic neuritis can often be the first presenting feature of multiple sclerosis, so they don't necessarily have to have MS in the stem. And often people will go on to get diagnosed with MS later on, but optic neuritis also does not mean that they have MS, because do people know what the requirements are for diagnosing MS? I think nobody likes to talk in this one. Oh, have we got something in the chat?
Yeah, so multiple lesions disseminated over space and time. So MS, yeah, and greater than 2 lesions in space and time.
Perfect. Nice. Good job. So that's good. Okay, right. So you need, so if they have an episode of optic neuritis in the stem, that's only one episode. They need to have multiple regions. So in space, meaning in like different parts of the brain. So they need to have the MRI scans, and then over time, meaning they need to have more than one episode of either. So one episode could be optic neuritis, then one episode could be another part of the body being affected. So that's why you have to refer these people to neuro-ophthalmology after you see them in the emergency department, because they need to have the MRIs done so that you can document that, you know, there was this in this time, and then you can document later on there was a change in time. So interestingly enough, people think that with a patient that presents with kind of decreased visual acuity or red desaturation, and they're suspecting optic neuritis, they will see signs on the fundus. Does anyone know what typical signs on the fundus you might expect to see? Did I see something in the chat?
Yeah, so 2 people are saying nothing, and someone is saying because retrobulbar
Yes, exactly. Okay, good. You guys know it.
atrophy.
Right. So
And
yeah,
someone is saying atrophy.
yeah, yes, yeah. So you can see atrophy. That's really good, because we literally had a teaching session for the ophthalmologist, and like even the the older ones, they didn't know this a few days ago. So yeah, so most commonly you see nothing on fundoscopy because the inflammation is retrobulbar, which means it's behind the eyeball. And that's the most common case. Sometimes you can see inflammation of the optic nerve head, so some atrophy, etc. But that's the unusual case. So you have to mainly go on the patient's symptoms, and then obviously the visual acuity and the red desaturation. And they will get a typical pain on eye movements as well. Okay, nice. Next question. So there's a chart here. So this requires some interpretation of the chart. Once you've interpreted that, and then put that in association with the fact that the left pupil is dilated, and then let me know what you think could have caused that. So this is again one of the harder ones. I have tried to make the questions on a range to cater to different people.
So we have got A, C, yeah, another A and B as well. So I think, yeah, either tumor, hypertension, diabetes.
Okay, nice. And does anyone who said B or C want to give their reasoning? Just so that I know like how well to explain it to you guys.
So Lillian is saying cranial 3 lesion.
Yeah, that's right. Good job. Okay. Yeah. Okay, that's fine. So at least now I know kind of where to pitch it. So you're right. This is a cranial nerve 3 lesion. Well done for figuring that out. This chart is called a Hess chart or a Hess chart. HESS. And it's good to be able to learn how these work. So the normal place that you'd see the ocular muscles, again, it would be really helpful if I had a mouse here, is the red dashed lines. And any kind of change from that shows a change in the ocular muscles that you are seeing on the patient or an abnormality. So in this case, if we look on the left side, you are seeing generally the whole image is like contracted, so it's less. And on the right side, the whole image is bigger. The black lines are taking up more space than the red lines. And that is because on the left side, you're getting underaction of all of the muscles, except for the lateral rectus and the superior oblique. And on the right side, you're getting overaction of the muscles, of all of the muscles, except for the medial rectus and the inferior obliques, which are the yolks of the spared muscles. So essentially, there is a law. I won't mention it now actually because I think there's a question on it later on about the name. So I won't mention the name, but the law is essentially says that when you have like an underaction of one muscle, then you'll have overaction of the like the corresponding one on the other side. So that's why the image on the chart on the right looks bigger. And as we know, all of the muscles except for the lateral rectus and the superior oblique are the ones that are supplied by the oculomotor nerve, cranial nerve 3. So that's why we know it's the cranial nerve 3 that has been lesioned, because all of the other, because it's a smaller square. Does that make sense? So one thing is the size of the squares, and then the other thing is the actual direction of the squares. So that also helps to give it away. So we call it obviously down and out. So as you can see, the square on the right is a little bit more down and to the lateral aspect compared to the red dotted lines. And that's again because the lateral rectus and the superior oblique are the only ones that are working. I hope that made sense. So based on all of that, we can figure out it's the cranial nerve 3. So well done. All of you guys figured out that it was cranial nerve 3. And to be honest, all of these options show that it was a cranial nerve 3 lesion. But then the way to be able to differentiate the cause of the cranial nerve 3 palsy is you need to know a little bit more about the actual cranial nerve and how it works. So the correct answer was actually tumor, and I will now explain that. So if you can see here on the right, the yellow is the actual nerve, and the kind of the outline. So the way that the cranial nerve 3 works in the brain is it has two different types of fibers in it. It has the fibers that control the actual movement of the extraocular muscles, and then it has fibers that are responsible for the sympathetic and the parasympathetic action of the nerve, which are responsible for pupillary like dilation or constriction. So if the outer part of the nerve is affected by something like a posterior communicating artery aneurysm, then you'll just get compression of the outer fibers, and those are the fibers that affect pupillary dilation. So if they're compressed, it will cause dilation of the pupil, and that's why you get like down and out and then a dilated pupil as well. Whereas if you don't have the compression of the nerve from any external structures, but you just have the nerve is being damaged from the inside, for example, because it's not getting a good blood supply, then you'll still have damage of the ocular movement side of things. So on this diagram, the Hess chart will still look exactly the same, but the pupil will not be dilated because the pupil will just be normal, the same as the right pupil. So the differentiating part of this question was actually also in the last stem of the question, which says the left pupil is dilated. Does that make sense? I can't really see you guys, so I'm hoping that makes sense. It's a bit of a complicated explanation. But go in and learn Hess charts as well, actually. I would say learn them for all the different palsies because they could just show you one. This is what the third looks like. The other ones are a lot easier. So the lateral rectus palsy, for example, will be really easy. This one's the most complicated, so that's why I showed that here, just to help explain this one. So in terms, so I hope that helps to understand like why the pupil is dilated sometimes and sometimes why it's not in a cranial nerve 3 palsy. Now, the clinical importance of that is because if we look at the pupil, so we see the patient, the eye is down and out. Okay, it's a third nerve. Should we worry or should we not worry? We need to basically worry when the pupil is dilated, because when it's dilated, that's when we know it's something that is kind of like an emergency. So it could be a posterior communicating artery aneurysm. It could be any aneurysm of any of the arteries in the brain. But the reason we typically say posterior communicating artery is because that's the most common one. And that, as we know, can be life-threatening. So if they have that in the stem, the patient will need like emergency, referral to neurosurgery. And then the other thing that can cause it is anything that can raise intracranial pressure and cause uncal herniation, which will again compress the outer fibers of the nerve. And then you can also have a tumor because again, that is something that will compress the outer fibers of the nerve. And in all of those cases, you'll have pupillary dilation. In the kind of the other more typical cases, so most of the time actually it's not something that you need to be like, okay, like super worried about, because it's just medical, meaning the management is medical. So as you can see, for all of those other 3 things I mentioned before, PCA, herniation, or tumor, the management might be more surgical. But medical is the most common cause by far, and it's just something like either hypertension or diabetes or even like a migraine can cause it. And that's just because the inside like fibers of the nerve are being affected, but the pupil is not affected. And so that's not something we have to like deal with urgently. And the reason you need to be able to differentiate is because it affects your management in the emergency setting. Okay. So now we've got a picture of someone's forehead. I'm not going to describe it too much because that might give it away. Based on the most likely diagnosis from the picture, what do you think? Causes arthritic posture, ischemic optic neuropathy. Smoking may be associated with improved outcomes. Disease may be present with negative biopsy, or there may be an association with myositis. Have we got any answers, Miriam?
Yeah, we've got everyone is saying C.
Nice. Well done, guys. Okay. I'm glad I didn't pick D this time. Okay. Yes. So this picture is showing a essentially quite a nodular and thickened superficial temporal artery. And the reason A is wrong is because it was really close, but it causes arthritic anterior ischemic optic neuropathy. Smoking is bad for this. Yes, the disease can be present with a negative biopsy, and we'll go into the detail of that in a second. And D, no, I think the association with myositis is with polymyalgia rheumatica, although I can't remember exactly, but it's not with this. It's not with. So GCA is a condition in which you have inflammation of the arteries in your body. One of the arteries that can be affected is the kind of the central artery that supplies your eye, so the central retinal artery. And if that gets inflamed, then you will get this kind of typical cherry red spot appearance on the fundus exam. And that is just because the macula has a dual blood supply. So if you have a blockage, because the artery is inflamed or has become ischemic, then the whole of the macula will become pale, but part of it, the whole of, not the macula, the whole of the retina will be pale on an exam. That's why, it looks kind of not quite pinkish or reddish like we saw in the retinitis pigmentosa picture, for example. But the macula itself, because it has that dual blood supply, is still receiving the blood supply, and that's why it appears red, and that's why we call it like a cherry red spot. This condition is typically like when you get it, you get the inflammation of the temporal artery. So you get you might have tenderness of or like on the temples themselves if you press on the patient, or the patient might complain of scalp tenderness when they're brushing their hair, for example, or they might complain of pain in their jaw when they're trying to chew. And it can be associated with a headache as well. And the typical kind of patient that tends to present with it is an elderly female, and smoking is linked with the condition as well. What you want to do for this is you want to start treatment regardless of the biopsy findings. So the biopsy findings are great because they can help to determine whether you want to continue treatment in the long run. But like because they can help to confirm essentially your kind of, if you're going to give steroids in the long term, and we all know like the risks of steroids, we don't just want to keep giving them to a patient for no reason. So the biopsy, so that's why we do the biopsy, because it can help to back you up for that reason. But we want to start them either way, And to be honest, even if the biopsy is negative, we might do another one, or we might choose to give the steroids either way, because the actual inflammation of the artery can easily be missed on the biopsy, because it doesn't mean that it's going to happen throughout the whole artery itself, because it has something called skip lesions. So the disease skips part of the artery. Okay, so N1 sign. What law is this? This is why I didn't want to say one of the names of the laws earlier, because I didn't want to give the answer away.
B. Everyone has put down B in the chat.
Nice, good job, guys. Okay. So I think Herring's and Sherrington's are some of the oculomotor muscle laws, and Smuts law is not a real law as far as I'm aware. I don't know, I just made that up. Okay, so Snell's law. I've tried to cover as much as I could in a short space of time. I think we have already gone like a bit over an hour, so I will literally just try to keep it high yield. So you just have to know for diffraction, it's kind of dependent on the wavelength of the wave that's going through. So in our case, it'll just be light, and then the actual hole that it's diffracting through. When the wavelength of light and the space that it's diffracting through are similar, I think that's when you get the maximum. That one up. It's been a while. Sorry, guys, since I did the Duke-Elder, but that one's important. The other one's Snell's law, which you guys already know. Critical angle when the angle of refraction is 90 degrees. And for reflection, you just need to know total internal refraction is when all of the light is reflected by the interface, and that's how like optical fibers work, for example. Just briefly, again, because we don't have too much time, just going into the myopia and hypermyopia side of things. For myopia, you want to use these concave lenses for correction, and hypermyopia, you want to use the convex lenses. And then you have astigmatism as well, for which you might need a cylindrical or a spherical lens correction on top of the concave/convex lens correction. And you just this is just learn the two types of astigmatism. You don't need to go too deep into it for Duke-Elder, but just learn the regular and irregular. So the kind of the principal meridians, which are the longest parts of the lens in both the X and Y axes. Whatever the longest parts are, if they're 90 degrees apart, then it counts as a regular astigmatism. If they are not 90 degrees apart, then it will count as irregular astigmatism. Okay, a bit more on optics. If a patient has bilateral esotropia, which prism should you use? So here, essentially, the circle is representing the patient's nose, and the triangles are, so the pointy bit of the triangle is the apex of the prism, and obviously the other bit is the base.
We've got A's in chat.
Okay.
And someone is saying C.
Okay, nice. So it's C. So well done to whoever said C. So bilateral esotropia is bilateral inward deviation of the eye. And the answer will make a bit more sense once I go through this prism slide. So just learn that 1 diopter is something that shifts light by 1 centimeter at 1 meter distance. So what that means is, I hope you can see, oh no, sorry, last slide, almost there, guys. I hope you can see the diagram on the right. Sorry, it's a little bit blacked out by the Zoom thing, but essentially, if you follow the black arrow, so we're looking at the top diagram, if you follow the black arrow through the prism, the origin of the black arrow is going to be displaced in the prism. If it's a 1 diopter prism, it will displace that origin by 1 centimeter downwards at a distance of 1 meter. So if you measure the same ray that came in and you measure it 1 meter away from the prism, then you will see that same initial ray at a distance measured at a distance of 1 meter will be 1 centimeter below the center point, assuming the ray initially came in at the center point. I hope that makes sense. If I'm not explaining well, guys, just please feel free to say at any point, because obviously I know it makes sense in my head.
Got a question. So Ali's asking, is it not base out prism for each eye?
Okay, we'll go into the base in and base out in a sec.
Okay.
Yeah. So I'm just explaining what a diopter is right now. I hope that makes sense. And I'll explain the base in, base out thing. Yeah. So okay, so yeah, so diopter, that's what a diopter is. And then people think that because the image now has been displaced downwards from the center by 1 centimeter, it's going to be not erect, but that's actually not true. So if you imagine that your eye is where it says talking, that if that's where your eye is, and then the prism is your glasses in the front of your eye, and something's coming into your retina, something's coming into the glasses, and it's going through the glasses, and it's being displaced downwards. Although in reality it has been turned upside down by the prism, your eye will naturally turn it back upside up. And because your eye will just carry on that ray in a straight line, because your eye doesn't know the glasses are there. So your eye will actually carry that ray back on in that orange dashed line. And if you draw a line from that black line to the orange dashed line, it will show the image is actually erect. So the image is, first of all, it's these three characteristics of the image. So erect, virtual, deviated towards apex. So you need to understand that a normal one from a normal prism glasses is always going to be erect, because like I explained, even though the prism turns it upside down, your eye is going to turn it back upside up again. And that final image to the orange dashed arrow is going to be erect. For that reason, it's going to be virtual, because it's not actually a real image, because the real image was actually turned upside down. So your eye has made it virtual, which is again why the orange is on the left. The orange arrow is on the left side of the prism rather than on the right, and it's deviated towards the apex, because as you can see, the orange arrow is deviated towards the apex bit rather than deviated towards the base bit of the prism. And that's important because that's going to help us to answer the question that we just had about whether it's base in, base out. So as you can see, I think the question was esotropia. Okay, so esotropia is this first one here. Esotropia is inward deviation of the eye. Exotropia is outward deviation. Hypermetropia is upwards, and hypotropia is downwards. So esotropia, bilateral esotropia is, just imagine those two eyes at the top. They're both facing inwards. Now, the error in this case is that the eye is facing inwards. And the rule, based on the whole kind of diagram I've just explained, is that the way you'll be able to fix the error is if the apex that you're using for correction is pointing in the direction of the error. So in this case, the error is an abnormal inwards pointing bilaterally. So the apex should be pointing inwards on both eyes.
So that's why it should be a base out prism on both eyes, because if you do this, the rays will get deviated towards the nasal side on both sides, which is towards the apex of the lens, which will result in the rays going towards the retina of where the person's actual retinas are, which are more nasally than a normal person's retinas if they didn't have the esotropias.
What we mean by base in is kind of in means towards the nose. So if you can see on the lower diagram here, the base is towards the nose on the right, and on the left eye, the apex is towards the nose, so the base is out. So in this case, because the abnormality is an esotropia, meaning the direction of the error is in, so in towards the nose is the direction of the error. So we need the apex pointing in as well. So we need the base out prisms on both eyes. Does that make sense? So that's why C is base out. Does that make sense for Ellie?
Yeah, he's saying it does.
Yeah. Okay. Nice. So I think that is everything, guys. Obviously, it's not everything for the exam, but hopefully if you can learn most of the concepts on this, then you can learn a lot of the kind of quick wins for the exam. Does anyone have any more questions?
So we have got one more question. If there's only esotropia in one eye, why do both eye needs prism correction?
So they don't. So what do they have in one eye?
So if they have esotropia, so eye going
Yeah, esotropia.
yeah, esotropia.
So if they only have it in one eye, then they don't need it in both eyes. But the question just said bilateral esotropia.
Okay, thank you. Also, guys, I've just put in a link for the feedback form. So if you could fill that in. Perfect. Right. Thank you so much, Noor. It's been very useful, and I'm sure everyone found it useful as well for the exam. And good luck with the exam. And it does seem like you guys have done a good amount of prepping, so you'll be fine.
Yeah, it does. Good luck, guys, and thank you, Mariam, as well, for giving your time to do a little bit on the retina and the orbit.
Oh, no worries. No worries. Pleasure mine. Thank you.
Okay, bye, guys.
Right. I'll leave the call in case someone wants to fill in the feedback.